So with our increasing aging population, the demand for cataract surgery will increase. And we have to, as cataract surgeons, find a way to be better efficient. And one of the proposed ways is with immediately sequential bilateral cataract surgery. But we have to maintain quality and think about patient safety. So if I'm the patient, I love this idea. I don't have to take days off work. I can see out of both eyes more or less in a couple of days, so decreased recovery time, decreased days off of work, and it's just more convenient. And I don't have that awkward period where I can't see one out of one eye, totally unbalanced, but I can see out of both. From the hospital perspective, we can look at cost. It's just more efficient. We can probably do more surgery. There was a study out of Finland that says that ISBCS versus delayed can save 850 euros per patient. So there are a lot of advantages both to the patient as well as to the system. So the risks of ISBCS are actually low, more or less similar as delayed. The biggest feared complication for any cataract surgeon is really endophthalmitis. So imagine that you have a patient who do bilateral cataract surgery and they have bilateral endophthalmitis. That is a devastating, visually blinding, potentially visually blinding condition. Nobody wants to go through that. However, the literature doesn't actually support that. But in my opinion, that should be a never event. That should never happen. There are, of course, other complications like TAS or CME, but that is the main disadvantage. Another one to consider for the patient is I don't have the opportunity, if I have a refractive surprise, to go back and adjust my IOLs. Again, the studies on ISBCS don't actually support that. However, that is a theoretical disadvantage. So in terms of disadvantages or risks to the surgeon as well as to the health system, one is that in the United States, it's actually not standard of care to do ISBCS. So let's say you have a complication and then suddenly you're a physician that is not practicing within the standard of care. So you're put in a very vulnerable position, which we have to think about in our medical legal environment. Something else to consider in the US is reimbursement. Very interesting perspective that in the US, if you do ISBCS, your first eye is paid at 100%. Your second, that's done on the same day, is actually reimbursed at 50%. So there's an interesting thing to think about in terms of reimbursement to the physician as well as the ambulatory care setting or the hospital. So that current reimbursement model is a disincentive. So in terms of patient selection for ISBCS, I think of it in terms of pre-op planning, intra-op, and post-op. So in pre-op, you want to make sure that cataract surgery is actually indicated for both eyes. You want to think about, are there potential patient factors? Do they need general anesthesia, in which I might want to do ISBCS? Or do they have to drive a really long distance? Other things to think about are there any relative or absolute contraindications for ISBCS? For example, let's say they have Fuchs, or they have corneal endothelial dystrophy, and then I'm thinking a more prolonged visual recovery. So I might want to hold off there. Or proliferative diabetic retinopathy. Maybe they have a slightly higher risk of complications. So ISBCS is certainly not for everyone. You certainly want to know, as a patient, the risks and benefits. So you have to go through a detailed, informed consent process. What are the risks, benefits, and alternatives for ISBCS? So that's pre. Intra-op, then you have to treat the procedure as an entirely different surgery. That means reprepping, redraping, rescrubbing. You want to try and do different lots from the IOLs or different batches for the irrigating solutions, just to potentially, you want to decrease that potential risk of an infection and complication. And if you do have a complication in that first eye, you abandon the second procedure. Post-op is a little bit different as well. So post-op, you want to do immediate antibiotics as well as, you don't want to patch. There is actually an ISBCS society with their recommended procedures, guidelines. They actually also do recommend intracameral antibiotics. Another thing to consider in the United States where that currently is not standard of care. So the literature has not shown that ISBCS is worse in terms of visual outcome, patient satisfaction, and complication rates. And in part, that's actually due to these increases in technology. So our phaco machines are better, we have less corneal edema. Now we have intraoperative aberrometry. We have different ways of calculating biometry. So even before we enter the operating room. So all of these advances in technology have really helped reduce those potential disadvantages of ISBCS. The rates of infection are about the same, or certainly no worse for ISBCS. And actually visual acuity in terms of outcomes are also about the same between ISBCS and delayed. It's hard to choose from such a wonderful and energetic conference. I have to say that something that is in the forefront of the American Academy of Ophthalmology as well as the SOE and globally is this idea of global patient safety. So things like wrong IOL, wrong sight surgery should be never events in ophthalmology. And I think as organizations, we really have to think of ways to reduce those errors. There was a particular slide that was shown today in that presentation where ophthalmology is actually on the top of the list of all specialties in terms of medical errors. That's not where we want to be on top. So I think patient safety is something that we all need to focus on.